So, the reason we're going to spend a whole lecture on efferent abnormalities is that some of these are worrisome. And the question is, which ones should you be worried about and which ones not? Sorry. And so we want to talk about causes of anisocoria and what ones are benign and which ones you need to pay attention to. So, when you see unequal pupils, if you see any of these, then you start to worry. First of all, if there's any other cranial nerve palsy with an anisocoria, that's a red flag. Obviously, if diplopia is present, because then we're talking about a cranial nerve palsy with a pupil that's involved. If you hear the patient say, I have the worst headache of my life, and they have an anisocoria, that's an immediate scan. I don't care what else you have. That needs to be investigated. Because worst headache of my life usually means a subarachnoid hemorrhage. Severe headache or facial ear pain. We'll talk about why, when you hear about facial pain, tooth pain, ear pain with an anisocoria, a dissection. Very good. You guys are way ahead of the curve. And then also the special situation of children with acquired Horner syndrome. What's the main cause of those and why we need to pay attention about that. So, the dangerous causes are basically divided into compression of the third nerve, which gives an anisocoria and bright light. We'll talk about that in a second. And then Horner syndrome. So that'll be sympathetic lesions, because those can be associated, as you said, with carotid dissection, tumors along the sympathetic, or brainstem stroke where the sympathetics come down the brainstem. And so really the dangerous ones we're trying to look at if they have a Horner's or if they have a pupil involving third nerve. This is on this module that you have the PDF about anisocoria, and I try to make a diagram that simplifies it. Remember, the first thing you should do is have a patient in clinic light, you're noticing an anisocoria. What do? I turn up the lights bright right away, or get a very bright indirect, because you want to see with very bright light whether you accentuate the anisocoria. So up here at the top, you don't know which is the abnormal pupil. Is it the bigger one or the smaller one? Nobody knows. But if you add bright light, if the anisocoria is even more prominent, then we know the bigger pupil is the problem, because you're doing something to bring out the weakness. So if it's a sphincter problem, you want to put them in bright light to bring out an asymmetry in the muscle that's being used when you have bright light, which would be the iris sphincter muscle. Now, it might be innervational. It could be an 80s pupil third nerve, but it might be pharmacologic, or it could be direct damage to the iris sphincter. And we're going to go through a bunch of cases at the end that kind of work through these things. If the anisocoria gets less in bright light, then you're thinking that maybe the smaller pupil is the abnormal one, because if it's a dilator problem, you're de-emphasizing the weakness in bright light. You're not using your dilator in bright light, so you shouldn't have much anisocoria if that's the cause of it. But it should be greater in dim light, because that's when your dilator is most activated. So using light at the beginning of your exam to sort it out is very important, to have a construct in your mind why you're doing that. You're just trying to find out if it's the sphincter muscle or the dilator muscle. That's basically your job in the beginning. Yes?
When you did the light, when you said the right eye were...
So dimming the light here.
Yeah. The eye to the left in the picture is the pathological one.
Yes.
But in Horner, you still have a
dilation lag.
You have Efferent defect, right?
You have an efferent defect of the sympathetic. Yeah.
Still you have a response.
To light, yes, because it's not Horner's isn't affecting the sphincter.
No, the dim light.
The dim light,
When you
yeah.
dim the light.
Oh, we'll go over that. Why, you're asking, why does the pupil dilate at all in dim light? We're going to cover that in just a second, but just to answer your question, think of what happens when you turn off the light. Two things happen to make the pupil dilate. First thing is at a central level, you inhibit the parasympathetics. So that's happening at the Edinger-Westphal nucleus level. And the second thing, then the sympathetic kicks in. Think of it like a turbocharge. And so your pupils can still slowly dilate without any sympathetic at all because of the central inhibition of the parasympathetics when you turn off the light. But it's this accentuation of the dilation, and we're going to show you how to look for that on exam. Okay, that's the key. I love it because you guys are a step ahead of me, and that means you understand this better. That's good. Okay, so again, if the anisocoria increases in bright light, we know we've got a sphincter problem, and those are the things we're going to cover. And if it accentuates in dim light, we know we've got either a Horner's or a physiologic anisocoria, and we have to differentiate those two, because physiologic anisocoria is very common. Okay, here's a patient who is on a second marriage, just getting ready to get married, had a 50,000-mile checkup at the Mayo Clinic. Everything was fine. They took their honeymoon in Europe, in Netherlands, and he slipped on the dock. And didn't think of anything of it, but after he slipped on the dock, he noticed he was having a lot of left toothache. So much so that the honeymoon was shortened, and he went home to his dentist, who promptly took out a tooth, which didn't help the toothache at all. And then he was shaving and noticed something was different about the two eyes, and he went to his ophthalmologist. And the ophthalmologist made the correct diagnosis. And you can see there that not only is that pupil smaller, but there's a difference in fissure. And you'll see that not only is the upper lid lower, but the lower lid is higher. So we call that an upside-down ptosis. Because remember from your anatomy that there's two muscles in the lid. There's the regular striated muscle, the levator muscle, and Mueller's muscle, the smooth muscle, which is present both in the upper and the lower lid, which is innervated by the sympathetics. Here's a video that's going to emphasize this point about dilation. What you're going to see is I'm going to first turn on the lights bright, and both pupils are going to come down, and the anisocoria is going to appear less. And then I'm going to turn out the lights, and I want you to watch the dynamics of the dilation. You're going to see this pupil dilate very fast, and this one is going to dilate very slow. And as a matter of fact, if you keep just waiting, it will eventually catch up to the other pupil, but not completely. So let's watch. Now I'm going to point out in the beginning of the video the upside-down ptosis too. So you see there's scleral show on this side and not here. Now we're going to turn on the lights. So both pupils come down, and the anisocoria is still present, but not as much. And I turned out the lights. See how fast the right pupil is dilating? But this one is so slow. It's still dilating. Keep watching. Because it's capable of dilating from the parasympathetic inhibition centrally. Okay, so people call this dilation lag. Now, if you are in the lane and you want to accentuate this to really show this difference, then you want to give a sympathetic stimulus. So what I do is I shut the door, and you have in your exam lanes you have a spotlight over the slit lamp.
Yeah.
Okay, so you have that light that you can turn off and on. The room lights are off. And so you have the light on, and then you're going to take a pen light from the bottom so you can just kind of obliquely see both pupils when you turn out the light. And then when you turn out the light, you want to go, And that stimulates the sympathetics. And what you're going to see is the normal pupil dilates like crazy. Every one of your pupils were dilating really fast. But the one with the sympathetic denervation just is still slow because it doesn't have that turbocharge. And now you're all awake.
And I have a question.
Yes.
The reason the pupils are still anisocoric after the bright light, is it because there is always a little drive from the sympathetic nerve in the healthy eye? Or what's the reason
That's
for that?
part of it. And also the sphincter parasympathetic is unopposed by any active dilator, even though, so it's not shut off completely. But also, as you said, there's some a little bit active sympathetics that in the other eye too.
Even in
Yeah.
bright light?
Yeah. And then this is a pupil tracing to kind of emphasize what we just saw in the video. So here we're going to turn the light on for a second and then off. So there's about a 1 millimeter anisocoria. At the peak of contraction now there's a little bit of anisocoria but not much. And then you see during the first 1 or 2 seconds, both pupils start dilating about the same rate because you're turning off the parasympathetic centrally. Now, at about 5 seconds, the sympathetics start kicking in the normal eye to accentuate it. But this one is just slowly dilating from this parasympathetic centrally being inhibited. So if you take a picture here, the anisocoria, or if you're watching when you turn out the light from below, the anisocoria will be greatest at about 5 seconds because the normal pupil is dilating with the sympathetic stimulus. But then if you wait at about 15 seconds, you'll see the anisocoria gets much less because this passive dilation keeps going on and it's bringing the Horner's pupil at a bigger size. It won't reach the size of the other one usually, but the anisocoria lessens. And that's what people call dilation lag. So the dilation is lagging behind in the Horner's pupil. To hear that term, dilation lag. Now, remember I showed you the RAPD with the eyelid response? This is going to blow your mind. Here's a Horner's patient, and from the video we were getting the eyelid borders besides the pupil borders. So the black line is the normal eye's pupil and the Horner's pupil. And you can see that it's very slow to dilate in the Horner's eye, right? Compared to that. Now here's the eyelid response, the two eyes. I'm going to blow that up. Look at that. If the eyelid, if you had a way of recording the eyelid, it has a dilation lag too. Because Mueller's muscles in the eyelid and the fissures were getting smaller with a bright light. And we turn out the light, the lids have to widen, and that's partially mediated by Mueller's muscle. And so you actually see a slow opening of the fissure compared to the normal pupil. So just giving you a preview of what's to come in the coming years as we are able to segment this from video, that we can use not only the pupil, but the eyelid dynamic response in the Horner's to help make the diagnosis. So back to our patient, just as you said, he was investigated and he had a carotid dissection. Here's blood in the wall of the carotid. With carotid dissections, the most critical time period is during the first week, because that's where a dissection is likely to cause an intimal thrombosis that can go up and give a stroke. Because carotid dissections is the most common cause of stroke in a young person. And these can occur spontaneously, but they can occur with sporting events too, with all kinds of things where you're turning your head and doing this. And there was I'll tell you a funny story. We have an annual Neuro-oftalmologi Society meeting in the US for North America. And one year there was a lecture about dissections after roller coaster, amusement park, because of the G-forces. And that evening, the social event was at Walt Disney Studios for the roller coasters. Not many of us went on that ride. Now, let's say that, here's another important point. Not every Horner's is complete. Matter of fact, most of them are partial. In other words, you're not damaging the nerve completely, you're not transecting it. And so some of these signs that we just went over are subtle. And you're wondering, is there dilation lag or wasn't there? Because maybe you've only damaged 30% of the fibers, not 90% of them. And so there's a little bit of ptosis, a little bit of anisocoria. Maybe the dilation lag's not so obvious to you and you're wondering, I'm not sure. And so you want to use some pharmacologic methods. Now, it used to be all we had was cocaine to do that. And let's just talk about cocaine and its use. Remember what cocaine does. Cocaine blocks the reuptake of norepinephrine that's released from the nerve terminal. So normally, here's a sympathetic nerve, here's the dilator muscle. Normally, the norepinephrine is being released into the synaptic cleft. And cocaine, in order to terminate the response, some of this is broken down, but some of it is just taken back up into the vesicles. Cocaine blocks the reuptake so that norepinephrine accumulates in the synaptic cleft. That's why people abuse cocaine, because it's like an amphetamine high, because you're accumulating norepinephrine if you snort cocaine. And so the normal response of a normal pupil will be to dilate, right? Because if you give cocaine drop in both eyes and you wait 50 to 60 minutes, you have to wait that long, it will accumulate in the synaptic cleft and it will stimulate the dilator muscle more and you'll get a mydriasis. You may get some mydriasis in the Horner's pupil, but not nearly as much. It depends on how many fibers are left. Right? And so with cocaine, after 50 to 60 minutes, you'll see an accentuation of the anisocoria. It's a useful test. The problem is it's what I would call a negative test, meaning it does something to the normal pupil in its lack of a response in the abnormal pupil. But it's useful. But the problem is it's a controlled substance. It's hard to keep in the hospital without you signing out for it, and it's difficult to keep in every clinic. What's the question again? Will the response be the same for what other kind of drops? Okay, so since this is not affecting the sphincter muscle, the sphincter will respond the same to tropicamide or cyclogel. What do you think would happen to norepinephrine, though, if you gave just phenylephrine drops? Because that's stimulating the dilator, right? Do you think the dilator would be the same sensitivity, or undersensitive, or oversensitive? Okay. Somebody says under. Who votes for under? Who votes for oversensitive? Who doesn't? Who's afraid to vote? Okay. Well, what happens when?
I think it will dilate.
Okay. Why? Do you have any idea why?
Because in one is a sympathetic issue, right?
Yeah.
So the nerve doesn't release.
Correct.
And in cocaine, it prevents the reuptake of.
Yeah.
But in phenylephrine, you're adding.
Right. You're trying to stimulate these receptors directly, right? But when you have a Horner syndrome and you take away release, okay, what do you think happens to these receptors? They upregulate. Now here's the big question. How long does that take, do you think? Who votes for 4 weeks? Choices are 4 weeks, 1 week, 3 days. So who votes for takes 4 weeks? Okay, about 4 or 5 people. How about 1 week? Another 4 or 5. How about 3 days? Okay, it's about 3 days. It happens fast. And so you get super sensitivity just within 2 or 3 days. That's true for all autonomic nerves, whether it's on the parasympathetic side or sympathetic side. Now, why did I just spend an extra couple of minutes talking about that? Because, let's just talk about first, what's an abnormal cocaine test? Anyway, we said that the anti-sequoia is much greater after the cocaine, but how much is abnormal? And this was a paper that we did way back many years ago. And if you take normal subjects and give cocaine to both eyes and wait 60 minutes and look at the anti-sequoia that develops. So most of them have very little anti-sequoia, some have a little bit. And then you take 120 Horner subjects that were diagnosed not pharmacologically, but because they found the lesion, we had good dilation lag. Most of those have a much greater increase in anti-sequoia. But there's a little overlap here. Anytime you do a test, there's a little overlap between normal and abnormal. Remember, some of these may have very mild Horners. And so the point is that if you do the statistics, the odds ratio of it being a Horner is if you get about a 0.8 millimeter anti-sequoia after the test, that's pretty significant for it's going to be a Horner's. 0.4, 0.5, even normals can have some anti-sequoia that much after cocaine. So in general, about 1 millimeter, it's a slam dunk. It's a Horner's if you have after the cocaine, if you have a 1 millimeter anti-sequoia or more. So just some guidelines in terms of what's a normal or abnormal test. Oops, sorry.
Is there anyone using cocaine? I mean, drugs.
Thank you for clarifying.
Do we have it in Sweden? Yes, yeah.
Well, we'll talk about why you would want to use cocaine in just a second. Because most of you may be now using iopidine or aproclonidine. So here's a patient with Horners in the darkness before, and here's after aproclonidine is given to both eyes. What do you observe there? So, first of all, what happens to the normal pupil in darkness after aproclonidine?
Constricts.
Gets smaller. So we have to think about why that happens. And then the abnormal pupil gets larger. And there's one more effect there, it's there.
The upper eyelid.
Right, the eyelid gets wider. So what is aproclonidine? And how was this discovered? And what does it do? Well, back when you were just little babies, aproclonidine was used before brimonidine was invented. And it was used when people got YAG laser treatment to prevent pressure rises. And it's a alpha-2 agonist and a weak alpha-1 agonist. And if you remember, the sympathetics innervate the ciliary processes that produce aqueous humor. And so an alpha-2, if you remember from your pharmacology, alpha-2 receptors are on the presynaptic terminal. And if you stimulate those alpha-2 receptors, it prevents release of norepinephrine from the synaptic, from that presynaptic terminal. And so if you have a drug that has an alpha-2 effect, it inhibits sympathetic release of norepinephrine. Okay? So the alpha-2 agonist properties of aproclonidine predominate. So it lowers intraocular pressure because there's less sympathetic to the ciliary process. Aqueous production goes down and lowers intraocular pressure. And this group from Houston, Sandra Fraser Brown, they hypothesized, this was way back, in the early 2000s, I think, that if you had a patient with Horner syndrome, the pressure lowering effect wouldn't be that much in the Horner's eye. So that's what they did the experiment. But lo and behold, they got this result. They weren't anticipating it. And so remember, now we know why the normal pupil gets smaller, because I said the alpha-2 is strong. And so you're giving a pharmacologic Horner's, essentially. And why do you think it gets bigger? Because we said there's receptor upregulation if it's at least 2 or 3 days after the lesion. And now that weak alpha-1 predominates because there's receptor supersensitivity. So that's why you get the alpha-1 exaggerated in the Horners. But there has to be supersensitivity. So if you saw a patient in the emergency room that has you think has an acute Horners, okay, that's when you want to use a cocaine. Because aproclonidine may be falsely negative if it's within the first 3 days of the lesion, okay? And the other problem with aproclonidine, it's not a huge problem, but in infants, like less than 2 or 3 years old, it goes into the brain. And you remember with brimonidine, if you've been through pediatric ophthalmology, you don't want to use brimonidine in infants either because it causes CNS sedation and it causes respiratory depression. So these patients have to be monitored if you're going to use it. But that's another instance where you might want to use cocaine because you're going to get the opposite, you're not going to get depression, you're going to get activation. So that's another condition where in an infant, you might want to use cocaine instead of aproclonidine unless you've got a way of monitoring them carefully after the drop. Now, brimonidine, which came after aproclonidine, is a pure alpha-2 agonist. There's no weak alpha-1. So you can't use brimonidine to diagnose Horners. But I can tell you we've had a number of patients that get referred to neuro-ophthalmology for Horners who are on brimonidine in one eye. So they had an induced pharmacologic Horners from brimonidine with ptosis and smaller pupil. So just remember that. If you have a glaucoma patient who's getting treated just in one eye with brimonidine, don't be surprised if they have a Horners. It's a iatrogenic pharmacologic Horners. Okay?
Shouldn't the right eye, left eye,
Which one? This one?
It was a sympathetic A1 and A2 agonist.
Yeah, but I said that in a normal eye, when there's normal receptors, alpha-2 predominates. So it's inhibiting the release of norepinephrine in a normal eye without receptor supersensitivity. The alpha-1 is so weak it's overpowered by the alpha-2. That's why you see it only in the receptor supersensitive. Yeah. The other amazing thing, yes?
Actually, I tried phenylephrine, one person. I tried phenylephrine.
Phenylephrine, yeah.
Phenylephrine, excuse me. 1%, and to differentiate between first or post-ganglionic Horner, and it works.
Yeah, so the question is, will phenylephrine differentiate between a preganglionic and a postganglionic Horners? And what you're really asking is, will you get supersensitivity with a preganglionic Horners? Actually, you do. And so people have tried what you said, to use phenylephrine, but actually it's super sensitive whether it's pre or post ganglionic. So I'm not so convinced it's best way to differentiate pre from post ganglionic. So you can get super sensitivity, so the aproclonidine test works no matter where the lesion is. You still get super sensitivity at the end organ, even if it's 1 synapse or 2 synapses removed. The other thing I wanted to tell you is that that lid effect is fascinating because the pupil effect takes about 30 minutes after you put in the drops because it takes that long to penetrate the cornea, get into the anterior chamber. But the lid goes right through the conjunctiva and the Mueller's muscle. Within minutes, the lid will reverse. I mean, it's, while you're sitting there talking to the patient, you'll see all of a sudden the ptosis is gone. So it's pretty amazing when you see it. So watch for it next time. Okay. So the next question is, let's say you diagnose it, and now, as you said, do you localize it or what do you do next? Sometimes the history helps you in terms of localizing it, but often it doesn't. And usually you have to image them for both preganglionic and postganglionic. In the States, we've used hydroxyamphetamine. I'm not going to go over it because they stopped producing it as a way of localizing pre and postganglionic. And folidrine, which is the European they don't make that anymore either. So we don't have a pharmacologic means available anymore. But you really have to do an MRI to make sure they don't have a lesion. And we published a study a couple of years ago looking at about 120 Horners in terms of how often did imaging reveal the cause. And I'm sorry to say it revealed the cause in about 10%. So, and most of those were carotid dissections. So often you're going to come up empty-handed and not going to know for sure the cause. But at least you've ruled out tumors and dissections and worrisome things. But most of them, you're not going to find the cause, unfortunately. And then you follow them and make sure nothing else is going to happen to them. But most of them, most of the postganglionics are cluster headache and benign things. Preganglionics I worry about more in terms of small tumors that were not picked up.
Do you refer your patients for MRI? Like
I do.
Horners? What about CT?
Okay, so the question is not so easy to get MRI sometimes in parts of Europe, a CT scan or a CT angio. If you're worried about a dissection, I think a CT is fine because you're going to see blood in the wall of the vessel with a CT scan easily. But other lesions, it's not as sensitive, but if that's all you can get, it's better than nothing. Just remember the pathway of the sympathetics, just to review. Remember, it starts, first order neuron starts in the hypothalamus, goes down the spinal cord, and synapses at about C7 through T1, T2. And then the second order neuron loops around the subclavian artery, synapses at the superior cervical ganglia where the carotid bifurcation is. And then it follows the carotid artery up to the eye. There's branches that follow the external carotid artery that supply the sweat glands in the face. And the ones that go up the internal carotid artery supply the eyelid, the pupil, and a spot right here, about that size above the brow for sweating. So sometimes, a lot of patients don't realize they have an asymmetric sweating. But if they happen to have it, and you know the pattern of it, you can localize it. So if it's loss of sweating in the whole body, it's a central lesion. If it's just the lower face, it's got to be along the external carotid. If it's pupil in this area, then you know it's along the internal carotid. So if they do have a sweating asymmetry, most patients don't notice it. It might help you. And then you asked a question yesterday, I'm going to repeat for the rest, is that can you get a dissociation between pupil being involved but not the lid, or the lid being involved and not the pupil? And it's a good question, because if you look at the topographic distribution of the fibers in the sympathetic nerve, like other cranial nerves, there's bundles. And there's a bundle for the pseudomotor sweating fibers, there's a bundle for the vasomotor fibers, there's a bundle for Mueller's muscle, and a bundle for the dilator. And they're segregated in the cross-section of the nerve. So depending on the lesion, you could take out more of some of the end organs than others. So the ptosis is not always proportional to the amount of anisocoria. Usually both are affected, but maybe not in the same proportion. Don't let that surprise you. It really depends on what part of the sympathetic nerve is being affected topographically. Okay, so mainly summary of the dangerous causes of tumors, dissection, and stroke for the sympathetic side. I just want to take the last 10 minutes and cover the parasympathetic side. We're talking about a postganglionic denervation, 80s pupil involving third, pharmacologic mydriasis, and direct damage to the sphincter muscle itself, not nerve damage. This is an old picture because I made a big mistake when I was a fellow. And so we all learn from our mistakes, so you're going to learn from my mistake. I saw this patient a month before she looked like this, and she was referred for evaluation of temporal arteritis because she had right-sided headache. And her eye exam was completely normal except for a 1 millimeter anisocoria, where the right pupil was bigger. no motility problem, no diplopia, and I blew off the anisocoria. I just thought, well, she's here for a temporary biopsy. There's no third nerve palsy. It's probably benign anisocoria. And we did the temporary biopsy and it was normal. And she called me a month later and said, I just woke up and my eyelid is down. And so I said, come in right away. And I lift the eyelid and the eye's exotropic now. And she had a pupil involving third nerve. And she had a posterior communicating artery aneurysm. And that was a case where there was pupil involvement a whole month before motor involvement, because I wasn't paying attention to the anisocoria and not working it up. So doesn't happen very often, but it got my attention and I remember it now all these years. And we'll cover this in the third nerve lecture later on, but here's the anatomy. The eyes are over to the right, that's the olfactory nerve up there. And PA is a posterior communicating artery. And right underneath it, lateral to it, is the third nerve. So the posterior communicating artery lies just medial to the third nerve, and which we'll cover this afternoon with the third nerve lecture. The pupillary and accommodative fibers lie on the medial side of the third nerve. So something compressing like an aneurysm from the medial side will take out the pupil and accommodative fibers first. Now obviously if there's a sudden enlargement of an aneurysm, it's going to take out more than that, but anatomically that's how this happens. Sometimes the pupil and accommodation are affected first, or more than the motor part. Here is a patient that came in with worst headache of their life, neck stiffness, and double vision. And let me just show you the video of what she looked like. So obviously there's pupil involvement. She's exo. She abducts the right eye just fine. Can't get that eye up compared to the other side. Can't get the eye in, can't adduct, and can't get the eye down very well. So she had a third nerve pupil involvement. What did she have?
The investigation of choice in this case is MRI.
Okay, so that's the question. What's your first move? Is it an MRI scan? Is it an angiogram? Is it an MRA? So, so the question is, what's the differential diagnosis of a pupil involving third nerve? Not everyone's an aneurysm, right? That's the one everybody thinks of first. So, and that brings us to this slide. What are all the causes of an acute pupil involving third nerve palsy that's painful? So aneurysm, we got that one.
Tumor.
What kind of tumor? Because it's acute, not slow, gradual. What has to happen? Very good. So apoplexy, that pituitary tumor that has a sudden infarct because it outgrows its blood supply, and there's hemorrhage and edema, so it's a sudden expansion. And if it expands laterally, it catches one or both third nerves and the pupil in accommodation. If it expands upward, you're going to get a chiasmal problem, right? Sometimes both, chiasm and third nerve. So good. Pituitary apoplexy. Now it gets a little bit harder. What are next? There's a couple more. Sinus thrombosis. So that's not going to be an isolated third. That's going to affect more than three, right?
Meningitis.
What was that?
Meningitis.
Meningitis. So, okay, so meningitis is not likely to give an isolated third nerve. It could give other cranial nerves. But there's a couple other ones. Mucor, again, it's more likely to affect many cranial nerves, but that's a good thought. So here's our list. So Tolosa Hunt, which is a granulomatous disease, painful third nerve. That's in the orbital apex. Ophthalmoplegic migraine, we're going to talk about what the heck that is. But these are kids sometimes that first come to the emergency room with headache, and then they get a third nerve pupil involvement, and it can be repeated. An AV shunt called a white-eyed shunt. So some of these arterial venous shunts are directed posteriorly and get the third nerve without the red eye findings. Rarely an ischemic third nerve can be painful and have pupil involvement. We don't talk about it much because we don't want you to dismiss it as an ischemic third when you have these other more serious problems. And then giant cell arteritis can do this too.
Which way?
Isolated pupil involving third nerve from ischemia to the third nerve, but it's more like an infarct almost because it's not just ischemia, it's usually granulomatous thrombosis of the vessel going to the third nerve.
Are we talking complete or partial third nerve?
Okay, so the word partial is difficult. I use the word incomplete. So any of these can cause an incomplete third nerve. But one thing we're going to cover in this afternoon's lecture is there's an inferior and a superior division. And when either or both division is affected, all the muscles in that division are almost always affected in proportion. In other words, if it's an inferior division and it's partial or incomplete, I'll say, you should have the same amount of pupil involvement as adduction as infraduction. You don't have one without the other within that division. If it's a superior division, the amount of supraduction problem should be proportional to the amount of ptosis. You can't affect the end organs within that division disproportionately. Okay, it's just, you can't do it because they run so close together. So this was a patient that had this pituitary apoplexy. You can see there's both hemorrhage and edema. Sometimes it's one or the other or both. We're going to talk just a few minutes about 80s pupil. It's an acute denervation, postganglionic parasympathetic fibers to both the iris and ciliary body. It's almost always segmental. Once in a while, it will affect all the clock hours of the pupil. Just like on the sympathetic side, cholinergic supersensitivity happens within days. And then after 8 weeks, you get regeneration in most cases. But because the proportion of the fibers going to the sphincter compared to the ciliary body, remember the smooth muscle in the ciliary body for accommodation is much larger massive muscle than the sphincter, about 30 to 1. And so there's about 30 to 1 more fibers going to the accommodative muscles than to the sphincter muscle. So when both are affected and they're sprouting and it grows back, you get mostly the accommodative fibers grow back into the ciliary body and into the sphincter. So it's aberrant regeneration because accommodative fibers are now going back into the sphincter. You don't get a return of the light reflex. So when you get a light near dissociation in 80s, it doesn't happen right away. It starts at about 8 weeks. So if you see a light near dissociation in the context of an isolated efferent defect in an 80s, it's not acute, right? Acute, you'll affect both accommodation and pupil, and you won't get any reaction to light or near. And so just remember the location of the lesion is in the ciliary ganglion, and you're affecting both the accommodative fibers and the sphincter muscle. Here's some snapshots from a video. We'll finish up here in just a few minutes. Here's an acute 80s. Here's in darkness. In light, obviously you're now emphasizing the efferent defect in the 80s right pupil. Bright light, you're even driving down the normal pupil even more, so you're really accentuating the anisocoria. Near, there's no response because it's acute. Remember I said that's not reinnervated yet. And then if you give a 10% pilocarpine to both eyes, when you do a test like that, you always give it to both eyes. Because even a normal pupil can respond to a low-dose pilocarpine. But you're looking for an asymmetry, so it reacted more on this side. So there's some supersensitivity. Yes?
When we were talking about the horners, you said that let's take this.
Okay.
During bright light,
Yes.
shouldn't you have downregulation of the sympathetics?
The sympathetics aren't affected when you have a parasympathetic lesion. Those are two separate pathways.
I
Yeah.
understand that, but in 80s,
Yes.
we have a parasympathetic region, right?
Correct.
So sympathetic output is right?
Why do you say turn it up? It's
But
just,
it's only system working,
yes.
yeah? But the opposite for foreigners, you said,
The antagonist muscle predominates, you're saying it's, yeah.
in darkness, you said that in foreigners, after a while, it will dilate.
Yeah.
But in 80s, in bright light, it doesn't constrict.
Correct, because there's no innervation of the sphincter.
Yeah, I understand that, but
We can talk about it during the break more. Maybe I don't understand, because we're getting close to the break. We're going a little over time. 6 months later, same patient. First of all, in darkness, you notice the right pupil's a little bit smaller in darkness, not much. It still doesn't react to light, but now it reacts to near. So you see there's convergence, and that's getting smaller. And then, obviously, when you do a slit lamp exam, normally you see all parts of the sphincter circumferentially are reacting in concert. Whereas, if you look at the slit lamp in an 80s pupil, what you'll usually see is some segment is spared. See that segment right there is contracting, but the rest isn't. So that's when people talk about segmental palsy. Look at the slit lamp and see if you can pick up any segment that's still reacting to light. And it's almost 99% if you see that, it's an 80s. You don't need to do any pharmacologic testing. That's an 80s pupil if you see segmental palsy.
Mimic iris after trauma.
Yes, and I wish we had time for me to show you some of the cases, but unfortunately we don't. But let me show you the last couple ones on 80s. You've heard the term tonic 80s or little old 80s. So here's a patient that had long-standing 80s. And see how the right pupil is very, very small? And it doesn't do anything to light. But it does get even smaller to near. So sometimes that reinnervation, that aberrant innervation is so robust that that sphincter is getting those accommodative fibers grown into it and is staying constricted all the time, now even smaller than the other eye. So that's why in a chronic 80s, sometimes you just have a small pupil, not a big one, but it always will react more to near. So a near response, you'll even see it constrict more, but it doesn't react to light. And if you transilluminate, you can even see which areas are reinnervated that are contracting more. They look dark. This is infrared transillumination. I want to show you one more thing. Here's a bilateral 80s. To light, you see the right ones happened first, so it's more reinnervated and it's small. You didn't see any reaction, right? I want you to see how to do a near response. So I'm having them clicking my fingers and look at near. I want you to see how long it takes for the near response to develop. See, it takes about 5 or 10 seconds. It doesn't happen like that, like a normal pupil. So when you're trying to do a near response, I kind of give an auditory and visual stimulus to try to get them to really accommodate and keep them accommodating for about 10 or 15 seconds. Then you'll see it slowly come down. And then when I stopped it, you see it stays down. That's why they call it a tonic pupil. Because once you activate it, it stays constricted for a while. And so that's where the term tonic 80s pupil comes in. So I'm sorry we don't have a chance to go into the unknowns. Maybe we'll have some time this afternoon, I don't know. For unknown cases, it's pretty jammed up.
It's pretty tight.
Yeah.
We'll see what happens.
Okay, I'm too slow here. All right, let's have a break until what time?